All right, this afternoon we're going to pick up where we left off with regards to the scapula and its position on a thorax, which is what we've been focusing on all morning, thorax. I want to just say a couple things, largely because we had an opportunity to have lunch together and just reflect a little bit. First of all, Jonathan, you are an excellent person to work with. And I'm going to tell you why. Because I think it's important for people in the room who have taken this course in the past to know that no matter who we select from the audience, we always work around what we select, okay? We happen to select you. And the reason I'm excited about that is because you came in today neutral. Having a person coming in the second day neutral doesn't happen. So the gods were with me today, okay? They were with me. Now, if you would have came in today and you had a right BC, left AIC pattern, I probably would not have put that towel under your left side. Kurt, which side would I put that towel under? Right side. So for the people in the room that have already been embellished with what would you do, right, Mike, to get a right BC function, I probably would have gone about it a little differently. But the opportunity, Kurt, to have somebody come in neutral is like one in a million kind of things when you yesterday were a right BC. So I want to just tell you, we have on tape a neat person, a good person that responded the way I would want all of us to be taught. What is going on here with regards to this diaphragm and the thorax so we can get into the scapula as if everybody were neutral. The opportunity to see people walk in the clinic like you every time, Mike, is what? Less than 10%? Maybe that's too high, guys, I don't know. So isn't that cool? Thank you. I mean, that is a great opportunity because what it showed everybody is how easy it is to move non-manually and manually a diaphragm. That is so cool. We were commenting on it. People watching this tape are going to actually see this guy who looks pretty cool, neutral, and how we can just change your body with the direction of airflow. So that doesn't normally happen. So I just got to tell everybody who's watching this, that was cool. If you had a right BC pattern that was prevalent, I would have to go after it a little differently. And the message would have been the same, right, Jen? The outcome would have been the same. Our attitude would have been different. But it would have been presented in a different way. This is a better way to learn. And Kurt, that doesn't happen every day. So I just got to tell you on tape, that was an awesome experience for me. That was really cool. You're going to help a lot of people out because of that. In other words, the people that watch this are going to say, that guy looked neutral. And look at how he's moving those appendages around with air. Do you follow me? And you felt that. You witnessed that. You saw that. Second thing, I want to just go over a little bit with you. Did you remember this morning the amount of chondral bone, Brianna, in this area of your rib cage? And then you remember this morning also that I said right before lunch, the sternal, you asked about the sternum and or when would you do it or when would you not do it, I think is what you asked. It's a very highly sensitive area. It's a very movable area. And it's a very understanding, it understands the dilemmas it's put through, forgiving somewhat, but you know where it's at. You know where it's at. When it gets tight and pressure changes, you know you can't breathe as well. Restrictive clothing can do that. I know some people that wear restrictive clothing that drives them nuts. I have some patients that can't wear shirts. It can only be a certain t-shirt. If it drapes too high on one side, or we're all kind of like that. We have our favorite clothing. Some people who put bra straps on can't stand it because it's restrictive. Some people buy chairs and they take them back because it's too much. They can't, it's irritating. All I'm saying, it's irritating because you know it, you sense it. You sensed that this morning a little bit. What you don't know is going to happen is when chondral bone is going to sublux. I probably go, Mike, we talked about this last night. I probably go maybe 2-3 months now before I might hear a pop. I don't do as much clinical work as I used to. When I did a lot of clinical work, it'd probably be 5 or 6 times a year I get a little pop. Now, what does a little pop mean? A pop. A pop means you're doing something and all of a sudden you hear a click and you don't really know where it came from, but you can feel it. It resonates. And the patient's going, what was that? Okay? And the first thing you say, well, I broke your bone, you'll be in it. No. The first thing you say is, more than likely, that was something that was released. More than likely, it was chondral bone. It's where the chondral bone meets the true bone. More than likely. We had a course attendee in here last night that said, it just happened to me. Right, Mike? It just happened to me the other day. And I said, you know, this happens infrequently, but it does happen. And she wasn't even doing a procedure to treat, right, Mike? She was doing a procedure to test. She was just putting her hands on there and just seeing Jonathan if her patient could what? Breathe. And she heard a pop. She heard the pop when the person took the breath of air in. So it was a good thing, but it told you, Tessa, it probably needed to what? Happen. Here's what the patient said to her. Gosh, I feel better. You sure that wasn't my back there? That's something?
We get the opposite. If we don't get a pop, we get in trouble.
Yeah. I'm not picking because I'm so glad you're here. But Tyler, seriously, the physical therapist is sitting there going, oh, crap. Oh, my God, what did I do? And it could happen to anybody in this room, including the chiropractors. No big deal. Here's what's going to happen. They're going to usually feel better right off the bat. They're going to move better. My patients will say, boy, I know I needed that. And then about 48 hours later, they're going to be splinting. It's going to get sore. It's going to be tighter. It's going to be a little bit irritated. It takes about 2 to 3 weeks for those things to kind of get stable. All right? I see your head shaking, Kurt. Right, 2 or 3 weeks. That's normal. Now, I would expect that from anybody who's serious about the passion I had this morning. Do you follow me, Tyler? That's just part of the game. And I would expect that you would be able to explain to the patient that our goal is not to make anything pop, but our goal is to improve function, Rick. And if something gives, I'm going to make sure I use all my hands, my fingers. I'm not going to take one rib and try to move one rib. The only rib we're going to try to move this afternoon is rib number 1, first rib. But everything else you're going to be spreading out hands, getting 2 people to help out with, so these things can be minimized. But they're still going to happen. It's still going to happen. And when it happens, I don't want you to get all shaky and shuddery like, what did I just do? You know, if anything, it probably needed to happen. Now, I had a patient a few years ago. I'm going to tell you another story about this. I knew that she was a superior T4 syndrome, which we're going to get into real quick here. I knew her left side was very restrictive, and she was getting air over there, but not enough. And after we restored her ability to breathe, we found out that she needed more manual work on the right side, but she also was kind of like really stuck on the left side. And I knew that was kind of a different Brianna. It's like a pathological picture. So I told her, I looked at her, I said, Heather, I'm pretty sure when I do this technique on the left side, you're going to probably hear a little subluxation somewhere. Sure enough. I mean, no more did I say that. She took a breath of air out this time, and I guided the rib cage down, and there was that click. It was the second rib. And it was really the rib's attachment to the sternum, because we felt it. It was right there. Now, the first words out of her mouth she said was, oh my gosh, I haven't been able to do that in years. She goes, Ron, thank you. I don't care how sore I am here. Will I keep it? I said, you'll keep it if you keep your ribs moving, but I don't want it to be irritated, so we got to complete the entire process. I didn't stop, Tessa. I kept going. We had a subluxation. That didn't stop me, Brianna. I did everything else that we're going to talk about today, and she was appreciative of that, because if I would have stopped right then and there, where would the torque have been that would have created a lot of pain there in the future? Right there on that rib. So I had to disperse the torque off that rib by getting all the other ribs to what? Second take-home messages. You hear a little pop. Kurt, don't stop. Keep going. Because that little pop is going to hurt if you stop right there. Because now you got a person halfway treated Why don't you finish it off? Give them that rotation. And Tessa yesterday morning, I started off this weekend by saying, Friday I said, look, our goal is to get ribs to what? Alternate, rotate, shift, and move. That's what our goal is. We're not trying to isolate a rib with the exception of rib number 1 when I need to. And if you happen to isolate a rib because it's got a lot of torque placed on it, it's the weakest link in the chain, and it's the first one that's going to go. Look, you can't argue that might happen anytime on any one of us. So I wanted to kind of go over that. Osteoporosis is a good thing to ask about. But there are lots of situations, not like osteoporosis, that are equally as important to consider. For someone who has a hypermobile system, loose connective tissue, or someone that just recently had a surgery, or someone who has osteoporosis, or whatever the condition is, Tessa, I'm still going to work, use my best judgment on how much I can get that person to do without hurting them, without making them worse, by hurting them, breaking a bone. Never have done that, knock on wood. But I would still work on airflow. So you have in your manual coming up these diagrams of thoraxes that have arrows on them and up and down. Even if you had osteoporosis, I'm going to do everything I can to get that diagram in your manual to occur on that chest wall, even if I have to prop, position, and have people just gently hold to have the person treat themselves. So I would still use the same thinking, but I would modify it, Rick, on the condition I'm working with that clinically you should be able to do with good judgment based on the history that you took in and the information you received at the time you assessed them. So I can't tell you not to do it on osteoporosis. I would work with it, but I would limit it. I maybe really back up and say, you know what we're going to work on the first time you come in? We're going to secure your hips. We're going to make sure you understand where your hips are. So you have, Jen, a foundation. We're going to get you to learn how to shift because I don't know if you know how to do that. And then finally, all these debilitated patients. Who needs this more? Someone who's truly debilitated or someone who just wants to run faster? The people that are truly what? Debilitated. So I would give them some power with that diaphragm. Even if I'm taking a risk and I might be exceeding and I hurt them, I'm going to minimize that as much as I can. I don't have guidelines for osteoporosis or cancer patients or people who are feeling really bad. But I would not stop, Tessa. I come back to you. I would say, look, you have osteoporosis. You're in an extended state. You don't trust your body. You're going to bed every night thinking, did I break any bones today, Brianna? This woman says to me, Gail, there's no one you're going to meet. You happen to be taking a class with a woman that has broken how many bones?
Over 200.
That's your answer. And she's coming to this class, and she's going to tell you the only thing that got her to this point where she's not breaking bones a lot is what, Brianna?
PRI.
So I'm just saying, in this class, you have that person. I can tell you right now, her therapists were not afraid to push Brianna. Did your therapist break you a little bit once in a while?
Not so far, knock on wood.
Okay. Gail, I'm only doing this to teach because you don't know what's in this room. So I'm thankful you're here so people can hear on tape. The people that need this, Brianna, what did you tell me? Who needs this more than anybody? People like who?
Me.
Thank you. That can't what?
That can't move, that have, debilitating.
No coordinated activity, no control. You couldn't even walk. No stability, no stabilization, no direction on what start means and what stop means. How am I doing?
Yeah, exactly.
That's what I'm talking about. I'm just making sure you understand that. Did that help you guys? That's not a plug for PRI. That's a plug for diaphragm. That's what that was. So you understand the answer to that question. Good. Got all my bucket list to do things off my plate. Okay. Any other questions? Those are great questions. Anybody else have any questions about anything? Kurt?
Just a quick corollary. You and I were talking last night. It's easy when you're doing PRI, going through all the courses. Today and yesterday we're talking about ribs, but there's that extra drop test, extension drop test. You're going to get all these other tests you can do, centering and all that.